Good afternoon, everyone. My name is Petra, and my PhD is about investigating radioembolization as an option in the treatment of liver tumors. I'm a radiology resident and a PhD student. I'm working at the Medical Imaging Center. My vision is that we will not only treat but cure liver tumors with radioembolization, and I would like to achieve that by determining the efficacy and the safety of the isotopes used for radioembolization. So we are focusing on two main projects right now. The first one involves a systematic review and a meta-analysis about the safety and the efficacy of holmium radioembolization in the treatment of liver tumors, and the second one is a randomized controlled trial comparing holmium and yttrium isotopes in radioembolization. So I would like to start with my first project. So liver tumors are a global health problem. However, only 30 to 50% of these tumors are suitable for definitive therapies like surgery or resection. Therefore, there is a need for local regional treatment options. And these options include ablation, transarterial chemoembolization, and transarterial radioembolization. And according to guidelines, there are some scenarios when radioembolization can be the best choice because it can be potentially curative. So radioembolization has two isotopes in the clinical use, yttrium and holmium. And as you can see in this table, these isotopes have different characteristics. Holmium is a newer isotope, which has some advantageous properties that yttrium does not have. Holmium is suitable for SPECT and MRI imaging, and therefore we can perform more accurate intrahepatic distribution calculations and more accurate dosimetry. Also, holmium can be used as a scout and has a superior predictive value for intrahepatic distribution and dosimetry than the scout used for yttrium. So there is much evidence about the safety and the efficacy of yttrium for the radioembolization of liver tumors. However, evidence on using holmium for this purpose needs summarization and contextualization and needs to be more comprehensive. Therefore, our aim is to define the efficacy and the safety of holmium radioembolization. So we are interested in whether in patients with liver tumors is transarterial radioembolization using holmium isotopes safe and effective. Our primary outcome is tumor response, and our secondary outcomes are survival rates, adverse events, and apoptosis. So we conducted our search in 5 databases with the following search key, and at the end of our selection, we've got 20 eligible full texts. So my first outcome is tumor response, which we express in terms of disease control rate. Disease control rate refers to how successfully we prevented the living tumors from growing. And for assessing tumor response, we use two systems, the RECIST 1.1 system and the modified RECIST system. The RECIST 1.1 system measures the whole tumor size, including the dead necrotic part as well, but in contrast, the modified RECIST system only measures the viable living part of the tumor. And since we know that radioembolization does not primarily has its effect by cutting off the blood supply and therefore inducing ischemia in the tumor size won't necessarily reduce, and that's why modified RECIST, which only measures the living part of the tumor, is more relevant to us. So here you can see our primary outcome. The proportions refer to the ratio of patients whose tumors were controlled by holmium therapy. For the two studies, for the two systems, we have 6 and 5 studies covering nearly 200 patients. And the heterogeneity in the RECIST study was considered high, and the reason could be a lot of reasons, the population, the different tumor types, but the main underlying reason is that these are observational studies. So according to RECIST 1.1, nearly half of the patients had their tumors under control, but according to modified RECIST, more than 90% of the patients had their disease under control. And since we know that modified RECIST is more sensitive, we can say that holmium therapy was effective. And it indicates that holmium works for the actually clinically relevant outcome, which is the rate of the tumors that we could control by holmium therapy. So our first secondary outcome is survival data and overall survival data. And here you can see the individual forest plots at 3 and 6 monthly time frames. And here I would like to draw your attention to the size of the diamond. And as you can see, the uncertainty increases as the follow-up time increases. And that clearly indicates a need for a longer follow-up time clinical trials, which our second study will be. So our next outcome is severe clinical adverse events according to the CTCAE criteria. And as you can see, the diamond is close to 0 in every case, indicating that holmium therapy was safe. So we also assessed the severe laboratory adverse events according to the CTCAE criteria, and we found changes in 2 laboratory parameters, several changes in the increase in gamma-glutamyl transferase levels and the development of lymphocytopenia. And here we found something that needs to be discussed in the literature better, and in our second study we would like to discuss it as well. So our next outcome, here you can see that other severe laboratory adverse events were almost non-existent, and this indicates that holmium therapy was safe. Our last outcome is dosimetry data, tumor absorbed dose and healthy liver absorbed dose. And an increased tumor absorbed dose can increase the likelihood of killing the tumor cells efficiently, but limiting the dose to the healthy liver tissue is crucial in preventing severe complications like radioembolization-induced liver disease or radiation pneumonitis. And here you can see that the mean tumor absorbed dose was almost 3 times higher than the dose absorbed by the healthy liver tissue, which not only indicates that holmium therapy was effective, but it was safe, as the liver can handle up to 6 degrees without failure. So there are strengths and limitations of our study. The strengths are that it clearly answers the research question with sound methodology, and this is the first comprehensive evaluation of the safety. Thank you. And the efficacy of holmium radioembolization in treating primary and secondary liver tumors. Our study also has limitations. One big limitation is the very big heterogeneity across the included studies, that the outdated technologies used in previous publications limit the applicability and generalizability, and the lack of longer follow-up times. So in conclusion, holmium radioembolization can control liver tumor growth efficiently without major complications. The implications for practice is that holmium radioembolization is a good treatment option in unresecable malignant liver tumors, and the implication for research is that longer follow-up time are needed to assess the long-term efficacy and the safety, and that future research should aim to investigate the tumor-specific responses as well. So we would be able to publish our manuscript at the 30th of May in Cancers, and here is our manuscript. Not manuscript, article, yes. Okay, so our second project is a protocol of randomized controlled trial comparing the use of holmium and yttrium isotopes in transarterial radioembolization for the treatment of liver tumors. So as I mentioned before, radioembolization uses 2 isotopes, and these isotopes have different characteristics, and their safety and efficacy on different tumor types and different populations are not yet fully understood. Therefore, our aim is to determine if holmium has different efficacy and safety than yttrium. So we designed a randomized controlled trial with the more current patient population than our meta-analysis, with the same outcomes as our meta-analysis, comparing holmium radioembolization with yttrium radioembolization. So we would like to include adult patients with only hepatocellular carcinoma, and we would like to exclude patients with extrahepatic metastasis to reduce confounding. So the arm A of the intervention is radioembolization using holmium isotopes, and the arm B is radioembolization using yttrium isotopes. And our primary outcome would be tumor response rate according to modified RECIST at 6 months, and our secondary outcome would be tumor response rate at 1, 3, 9, and 12 months, dose-response relationship, survival data, and also clinical and laboratory toxicity according to CTCAE criteria. So to sum up, I have 2 projects. The first one was published in May 2025, and the second one, the planned submission date is August 2025. Maybe it's a bit early, but we try to do it. And here you can see my additional activities. I was presented our outcomes in several Hungarian and not Hungarian conferences, in the ECI and the CSHA conferences, and we are going to present our outcomes this September at CIRSA conference too. So I would like to finish my presentation with a quote: "Man can learn nothing except by going from the known to the unknown." Thank you.
Hey Petra, thank you for the great presentation. I was wondering if there is any difference in cost between holmium and yttrium isotopes.
Thank you for your question. Yes, it's a really relevant question, but no, they are cost exactly the same. They are both expensive. Yeah, because the production of these radioactive isotopes, yeah, it's complicated. And also the shipment and these kind of stuff, but there is no difference, so this should not influence our decision.
If I understood it correctly, these are typically the first medication of individualized medicine. Yeah, because you ask for a particular dosage. They prepared for every patient.
Yes, yes,
and
exactly.
This is going on for, I don't know, some 15, 20 years. Yeah, they never mentioned that.
I have another clinical question. This TARE procedure, how long does it take? Is it painful for the patient? Do they need any sedation or an anesthesiologist? Maybe. Thanks.
Thank you for your attention. The patient is awake during this procedure, and the radioembolization procedure, the exact procedure, takes only like an hour maximum, but only because previously we have to do a diagnostic angiography, so we can explore the vessels of the tumor. So to know that how selective can we be. And after that, we have to give a test isotope to the patient, which is a small amount of the holmium isotope in case of holmium and the technetium isotope in case of yttrium. And after that we gave that small amount of test isotope, we perform dosimetry and we can calculate the intrahepatic distribution. If the particles are going right to the tumor, they are going to the healthy liver tissue, so we have to be cautious not to radioembolize the healthy liver tissue, because these patients usually not have that good liver function anyways. So yeah, that's it. And then we will know that it goes to the tumor, it has a good vessel structure to it, and then we can perform the radioembolization with all these known things, and that this is a short time, so it's only like half an hour or an hour. Maybe in our department they can do it in like 20 minutes, so if they are good at it, so that's it.
And are there any side effects?
Yeah, the side effects. So there are no major side effects. The potential major side effects are radioembolization-induced liver disease and radiation pneumonia, but because of this planning procedure, we reduced these side effects, so these are not occurring. But radioembolization can have minimal side effects like a little of abdominal pain. You know, they insert a catheter through the arteries, so dissection on the radial artery or the femoral artery, or some hematomas, some like fatigue, nausea, these kind of things, but not big complications.
Could you please comment a little bit about the inclusion criteria of the patients? Do they had only one tumor nodule, multiple nodules? Were there any cutoff values for the nodules so the patients would be eligible for the intervention?
Yeah, so radioembolization is done when no surgery or resection or ablation can be done. So we usually do radioembolization when the patient has like 2 centimeters minimum tumor size, or maximum 8 centimeter tumor size, and the patient can have a maximum of 3 nodules in the liver. And this is when the patient is eligible for radioembolization, and these patients are in the studies. But between the studies, the tumor types are different, because we had really limited data, so we had to include every tumor types in this meta-analysis.
And another short question. Did you have the data to compare these patients with the patients that were eligible for chemoembolization? Is it better to do it? Is it the same?
So, yeah, there are meta-analyses about that topic. This is why we did not perform meta-analysis, because there are recent meta-analyses about this. And these meta-analyses show that radioembolization is actually better for the patient. It can be curative if the patient has like one hepatocellular carcinoma nodule. It can cure the patient, for example. Chemoembolization is always a palliative structure. So yeah, these meta-analyses said that radioembolization is the better choice.
So you mentioned that one of the limitations was that the short follow-up time,
yes.
right? It's interesting because usually the problem is that there is no follow-up time. In this case, the problem is that it was too short. So
yes.
Judging by everything you found out in your work, how would you inform their methodologies for the future? What should be that follow-up time that you would deem sufficient?
Yeah, thank you for your question. So radioembolization works slowly. So at 3 months, you can see with modified RECIST if radioembolization had any effect, but you should follow the patients up to 6 months, because even up to 6 and 9 months, the tumor will shrink. And that's why, so the studies in my meta-analysis had 3 months follow-up. And in that point, you're not always able to tell the objective effect of radioembolization. So you have to wait for 6 months, 9 months, and that's when they can surely tell, and that's why we need longer follow-up times.
You had lots of outcomes, so and you managed to present all quite well, so congratulations. My question is related to the survival probability pools on different follow-up times.
Yes.
You have a quite professional sentence here that, as we can see, the uncertainty of the estimate increase with time.
Yes.
Share, please, with the others how you know from this figure this.
So you can see this blue diamond, and the size of this means the confidence interval and the uncertainty. And you see that these diamonds range increases as the follow-up time increases. It becomes wider and wider, and that's how we know that the point estimate could fall anywhere. So that's why we would say
quite
that.
good, thank you. And it was a wise observation, actually. And I just note that the reason is, of course, that we have lots of censoring, I guess.
Yes.
So basically, the data at 30 months is based on much smaller number of patients.
Exactly, because of loss to follow-up.
Yeah.
Stuff like that.
Okay, so congratulations again,
Thank you.
and thank you very much for your presentation.
So congratulations for your nice publication.
Thank you.
And I would like to ask that I saw that in some figures you showed the lymphocytopenia and the GGT elevation. So what do you think, what could be the reason for that?
Thank you for your question. So yes, I looked it up because I was like, why? So there is limited evidence on this in the literature, but the reason for GGT increase could be that, so GGT increases when the liver receives some kind of stress. So it could be increased because of that. And also, radioembolization can cause temporarily bile duct obstructions, which are just temporarily, but this can increase the GGT levels after radioembolization for like a couple of months. And that's why GGT could be increased. And regarding lymphocytopenia, where the lymphocytes are extremely sensitive to radiation, and these are also circulating cells. So they go through multiple times through this radioembolized space, and that's why they receive a lot of radiation, which kill them. So this is why lymphocytopenia could occur, but we would like to investigate these findings better in our second study. Thank you
Thank you very much.